Today's discussion will be on cardiac pacing and defibrillators. Now, why these two topics are important is defibrillators has been asked as a theory question in the 2023 examination, in the October session. So it is very, very important to know about it. There are a lot of newer concepts that are coming in relation to defibrillators, which I'll be discussing. So that needs to be known. And in relation to cardiac pacing, usually it can come as part of bradyarrhythmias. If your question is related to bradyarrhythmias, probably 2 to 3 marks can be allotted specifically to transvenous pacing, that is temporary pace or permanent pacemakers. So it is important to have an idea about it, and its importance is more in your practicals. Especially, they will be keeping ECG scripts and rhythms related to pacemaker abnormalities, which you need to identify. So I thought this would be the best place to discuss about all these areas. So the first area I will be covering is on cardiac pacing. So under cardiac pacing, I will be covering about temporary pacing and permanent pacemakers. So in temporary pacing, the topics I'll be covering are introduction, the indications, the contraindications, the preferred vascular access, the procedure, pacemaker programming, and complications. So if at all you're asked based on temporary pacing, I think if you are able to answer it in these subtitles, then that would fetch you a good amount of marks. So coming to the introduction, temporary venous cardiac pacing involves electrical cardiac stimulation to treat symptomatic bradyarrhythmia until it resolves or until long-term therapy can be initiated. So the main purpose of temporary pacing is to re-establish normal hemodynamics that are acutely compromised by a slow heart rate. So as you all know, cardiac output is the product of heart rate and stroke volume. So if either of them are compromised, that will reduce the cardiac output and it will hamper the perfusion to various organs. So the heart rate is one of the main determinants. That's why there is a lot of emphasis on its management. So coming to the indications, you can have electrolyte disturbances like hyperkalemia or hypercalcemia, which can lead to bradyarrhythmias, leading to the need for pacing, or drug toxicities like beta blocker toxicity or calcium channel blocker toxicities. Post-procedural, that can be due to injury to the SA node or the AV node or the His bundle fibers, which can occur during post-cardiac surgery or post-heart transplantation or post-TAVI, that is transaortic valve implantation, or infections like Lyme's disease or Chagas disease. Though these are not common in India, it's more common in the North American states. And subacute infective endocarditis can also lead to bradycardia because of its propensity to damage the His-Purkinje fibers. Acute myocardial infarction itself can lead to bradyarrhythmias, as we all know, and permanent pacemaker revisions, which can be due to pacemaker related infections or lead failure. So in those scenarios where you need to change it, you can use temporary pacing as a modality to control the chronotropy. The most important mantra is should be kept for the shortest time possible. So coming to the contraindications, absolute contraindications, there are none. And relative contraindications, if there is a prosthetic tricuspid valve, there is a possible risk of damage to the valve. So it needs to be kept in the back of the mind. And if the patient has received thrombolysis, we need to be very, very precautious because any kind of injury to the endocardium can cause severe bleeding. So that also needs to be looked into, endocardium or the myocardium. So coming to the procedure part, so the preferred vascular access is either going for a right IJV or a left subclavian. Now, why this is preferred is one, the curvature of the pacing lead, the ease of advancing the lead into the heart, the underlying venous anatomy. So these are the main reasons why IJV is preferred. If at all the IJV is inaccessible, then you can go with the left subclavian. So coming to transvenous lead placement, usually only the ventricular lead is inserted. So the basic initial steps are like as for a central venous catheter insertion. So once the central venous access is secured, you pass the guide wire, and once the guide wire is inserted, then you place a sheath. Then the transvenous lead is inserted and is advanced based on markings from the distance of the tip. So this can be confirmed with either echocardiography or fluoroscopy. Now the important thing is if you're going to transfer for fluoroscopy, the patient has to be reasonably stable hemodynamically. And the most important thing is continuous EEG monitoring is recommended in all patients because VPCs or non-sustained VTs can be seen when the lead comes in contact with the right ventricle. So once the lead is in contact with the RV, then the lead is then connected to a pulse generator. So there are important things that you need to look into the pulse generator, which I will subsequently discuss about. So coming to the pacemaker programming. So the usual mode that is kept is VOO mode. It is the ventricle alone will be paced at a certain level. Whereas it will not have any sensing or there will not be any kind of response. There will be only a continuous impulse that is being generated. And that will lead to the cardiac action potential being excited, leading to contraction of the cardiac muscles. So the routine settings that are kept are the heart rate is usually kept between 60 to 70 beats per minute. The pacemaker sensitivity. So what is it? It is the minimum current at which the pacemaker is able to sense intrinsic rhythms. All right. So it is expressed in millivolts, and its significance is the lower the number, the more sensitive the pacemaker. All right. So it is usually kept between 0.8 to 20. So initially you keep it on the higher side and then you slowly come down. So usually the 0.8 should be the lowest number that should be kept because at that level, if you are able to sense the rhythms, then that is a good sign. Then you have the pacing output. So the pacing output is the current with which it produces a brief pulse. All right. So from the pacing generator, the current is being delivered through the leads to the right ventricle. So that is mainly determined by the pacing output. So it is the current with which it produces a brief pulse. Intrinsically, that pulse is produced by the SA node. All right. But in the event of bradyarrhythmias, there may be some kind of defect in your pathways, electrical pathways. So this transvenous pacing via the pulse generator takes care of that. Then the third important definition is the pacing threshold. Now the pacing threshold is the minimum pacing output required for the pacemaker capture. All right. So it is the minimum pacing output at which the action potential is generated, leading to a myocardial contraction. All right. So that is the pacing threshold. So for a pacing threshold, you need to have it at less than or equal to 1 milliampere. All right. And the pacing output should be 2 to 3 times of this pacing threshold. So these numbers in the settings should be memorized because we do deal with a lot of patients on transvenous pacing. So you need to know how to manipulate the settings in the event of any chronotropic issues. So, like I said, the heart rate should be set between 60 to 70. The pacemaker sensitivity should be kept on the higher side initially and then reduced gradually. The lowest should be at zero point 0.8. So, the lower the number, the more sensitive the pacemaker. Then, the pacing threshold. It is the minimum pacing output required for the pacemaker capture. Okay. So what is this capture? That is the minimum pacing output at which an action potential is generated, leading to a myocardial contraction. And the pacing output should be 2 to 3 times of the pacing threshold. So the pacing output is nothing but the current with which it produces a brief pulse. All right. So coming to the complications. So whenever the patient is being planned for a transvenous pacing, like any other invasive procedures, always the complications should be kept in mind. It should be anticipated. So that is why you need to know about it. So various complications can occur. Examples: lead dislodgement and disconnection, bleeding, myocardial perforation that can lead to cardiac tamponade, pneumothorax, infections, catheter knotting, and air embolism. So whenever you put a transvenous pacing, the patient should be examined on a regular basis for pericardial friction, which may be indicative of a cardiac perforation, hypertension with muffled heart sounds and distended jugular venous pulse, suggestive of a cardiac tamponade, and asymmetric or absent breath sounds, which may be suggestive of a pneumothorax. All these can be identified by focus itself, but from an exam perspective, when you're writing an answer, you need to mention about the clinical findings which you will look for in the complications. So that will add more value. So these complications need to be kept in mind. If whenever you are giving and whenever you are writing an answer, always have 5 examples in mind, other 5 possibilities in mind. Like if you have, they're asking about complications, have 5 complications that are likely to occur in mind. Or example, if at all they're asking a question related to a diagnosis following a clinical scenario, at least have 3 to 5 differentials in mind. So this is just for knowledge purposes, and it will help you from a theoretical perspective. So coming to the guidelines in relation to pacing, there was this 2021 VSC guidelines. So they have said that pacing is indicated in symptomatic patients with bradycardia, tachycardia form of sinus node dysfunction to correct bradyarrhythmias and enable pharmacological treatment unless ablation of the tachyarrhythmia is preferred. So it is considered like a 1D indication in cases of sinus node dysfunction. And pacing is indicated in patients with atrial arrhythmias, mainly AF, and permanent or paroxysmal third or high degree AV block, irrespective of the symptoms. So that is a 1C. So these are the scenarios where you can go with pacing. All right. So we completed about temporary pacing. Now we will come to the permanent pacemakers. So under permanent pacemakers, these will be the areas that I'll be covering. That is general considerations, indications, contraindications, parts, pacing nomenclature, pacing rhythms and abnormalities, and complications. So coming to the general considerations, with regard to permanent pacemaker insertion, most management decisions are driven by the following factors. One, association of symptoms associated with bradyarrhythmias like dizziness, lightheadedness, syncope, fatigue, and location of the conduction abnormalities, whether it is infrahisian AV blocks, second degree Morbitz type 2, or third degree heart blocks. In these cases, permanent pacemaker insertion has shown to improve outcomes. And the most important thing is you need to identify whether there is an absence of a reversible cause. Because if there is an absence, you don't need to put the PPA. So coming to permanent pacemaker insertion, you have class 1 and class 2 indications. So the class 1 indication is symptomatic bradycardia. Symptomatic sinus bradycardia due to long-term drug therapy of a type and dose for which there is no accepted alternative. All right. Complete heart block with or without symptoms and symptomatic second degree heart block. And class 2 indications are sinus node dysfunction with unexplained syncope, asymptomatic second degree heart block, Morbitz type 2. If there is a trifascicular or a bifascicular block associated with syncope and post anterior wall MI, leading to bradyarrhythmias. So in these subset of patients, you can go with permanent pacemaker insertion. So coming to the contraindications, here excessive risk of bleeding due to the vascular access, like there is any presence of coagulopathy present, or the patient is in sepsis, that is ongoing bacteremia is present, if there is presence of an intracardiac thrombus or presence of prosthetic tricuspid valve. In these scenarios, PPI is a strict no. So coming to the parts. So you have a battery, the power source that generates the impulse. Then we have a circuit that controls the pacemaker operations. Then you have the pacing leads. All right. So these are insulated wires that delivers electrical impulses from the pulse generator to the heart. And at the end, you have the electrode tip, the conductor at the end of the leads that delivers the impulse to the heart. All right. So the battery and the circuit together forms your pulse generator, and the insulated wire, that is your leads, and the electrodes together comes as your pacing leads. All right. So the pacing nomenclature. So this was updated by the committee from the North American Society of Pacing and Electrophysiology and the British Pacing and Electrophysiology group. So they are combined and come up with this. So it has 5 areas, 5 positions that needs to be uh, known about. The easiest way to remember it is by the mnemonic PSR RP. All right. P is for pacing, S is for sensing, R is response to sensing. Then the other R is rate modulation, and the last one is multi-site pacing. Okay. So here you can see O is none, A is atrium, B is ventricle, and D is due. So I think many of you would have received patients with pacemaker in situ, and if you see the discharge summaries, most of the time it will be DDDR. Like that will be the most commonest setting that will be present in most of the permanent pacemakers. So certain areas that they usually ask are what is rate modulation? So it uses a physiological sensor other than the sinus node to adjust the pacing rate according to the physiological need of the patient. So that is what rate modulation means. And multi-site pacing, which is not commonly used, but what it means is anti-tachycardia or resynchronization functions in addition to your pacing. All right. So there is another important terminology that needs to be known about, that is called overdrive pacing or anti-tachycardia pacing. So this is supposed to be one of the modalities of treatment in cases of atrial fibrillation or atrial flutter. So it creates a re-entrant pathway that bypasses the AV node or an ectopic unregulated pacemaker. So it how it does its process is it acts by disrupting the re-entrant circuit or overrides the ectopic pacemaker and changing the pattern of depolarization and creating more uniform repolarization. So this is the mechanism of how overdrive pacing acts. In refractory VT, overdrive pacing increases the rate of depolarization. So because of that, it helps in decreasing the ventricular refractory period, reducing the susceptibility to the R-on-T phenomenon. All right. So in refractory VT, overdrive pacing increases the rate of depolarization. So because of the increase in rate of depolarization, there is a decrease in the ventricular refractory period. So because of that, there is a reduction in the susceptibility to the R-on-T phenomenon. So AV junctional tachycardias, atrial flutter, and SVT with rapid ventricular response that fails to revert can be controlled with overdrive pacing. So these need to be kept in mind. So how do you actually do it is an external electrical impulse at the rate of 10 to 20 beats per minute greater than the native rate. So that is all that is needed. So it's not about any rocket science. It is pretty straightforward. So you just need to keep it 10 to 20 beats per minute greater than the native rate. So that is what is about overdrive pacing. So here is an ECG rhythm that you can see. Here you can see normal atrial and ventricular pacing spikes. Atrial and ventricular pacing spikes. All right. Here you can see ventricular pacing spikes alone. So ventricular pacing spikes precede each QRS. So coming to the pacing abnormalities, the most common abnormality is failure to capture or pacing failure. That is ventricular spikes that you can see here in leads V3, V4, V5, and V6. There is ventricular spikes present, but there is no pacing thereafter. All right. So the etiology related to the failure to capture are lead dislodgement or malposition. That is supposed to be one of the commonest cause. Then there can be inflammation at the electrode surface or battery depletion can be there. Pulse generator failure can be there. Lead maturation can be there. Or there could be a magnet that has been applied. So if there is a lead dislodgement or malposition, you need to reposition the lead. And if there is inflammation at the electrode surface, you need to reposition plus increase the output of the pulse generator. Whereas if there is battery depletion, you will need to change the battery. If there is a pulse generator failure, you need to replace the generator. If there is lead maturation, you will have to evaluate the change in sensing. And if there is a magnet application, you need to remove the magnet. So if you know the structure of a permanent pacemaker, you will be able to understand the complications or the area the problems can occur because of failure to pace capture. All right. So you can see, it's seen in the initial previous diagram. So the parts are battery, electrical circuit. So if there is any abnormality over here, if there is these two together are called the pulse generators. So if there is any issue over here, you'll need to replace that. If there is an issue in the battery, you need to change it. If there is a magnet placed over the circuit, then you will have to remove the circuit. If the electrode tip is coming in erosion or there is bonds, then you'll have to increase the sensitivity. And if the wires are malpositioned, then you'll have to reposition it. So one subset of abnormalities were related to failure to capture. Then you have another set of complications that are rapid ventricular pacing. So rapid ventricular paced rhythms, that is more than 120 beats per minute, with no evidence of preceding atrial activity, except for the first complex. So there are two possible differentials that we need to consider. One is pacemaker-mediated tachycardia and sensor-induced tachycardia. So for pacemaker-mediated tachycardia, the temporary management is to place a magnet and change to asynchronous mode. Whereas the definitive management is reprogramming of your pacemaker. Here is a ECG of a runaway pacemaker. So you can see paroxysm of rapid pacing spikes of 2000 beats per minute with decreasing amplitude and rate. So now why this is so concerning is this low amplitude will fail to excite the ventricles, and because of that there is no cardiac action potential and there is no excitation that is going to occur, and because of that there is no contractility. All right. So this is about runaway pacemakers. Now, the important thing to note is this pacemaker mediated tachycardia, these runaway pacemakers were all more seen with the first generation of pacemakers. That was the ones in which these complications were more seen. But in the newer generations of pacemakers, they have made the circuitry more refined. So the risk of complication in relation to this is very, very low. So if the pacemaker, runaway pacemaker is there, you will have to disinhibit the pacemaker first to the magnet. Then emergency place a temporary pacing device if the patient is pacemaker dependent. And the definitive management is reprogramming of your pulse generator. That is, the electrical circuitry needs to be reprogrammed. So the complications were similar to those in relation to your transvenous pacing. Lead dislodgement or disconnection, bleeding, myocardial perforation that can lead to cardiac tamponade, pneumothorax, infections, catheter knotting, air embolism, runaway pacemaker or pacemaker mediated tachycardia. So we have completed transvenous pacing and permanent pacemaker insertion. So the next topic that we'll be discussing is on defibrillation. So under defibrillation, we'll be discussing about the introduction, the types, the mechanism, the factors affecting defibrillation success, the indications and energy selection, the complications, double sequential defibrillation, and ICDs, that is implantable cardioverter defibrillator. So coming to the introduction, electrical cardioversion and defibrillation have now become routine procedures in the management of patients with cardiac arrhythmias. This is one thing which all of you would know. Cardioversion is the delivery of energy that is synchronized to the QRS complex, whereas defibrillation is the non-synchronized delivery of a shock randomly during the cardiac cycle. So there are various types: manual, automated external defibrillation, and implanted cardioverter defibrillator. So the mechanism of its use. So defibrillation is the passage of an electrical current of sufficient magnitude across the myocardium to depolarize a critical mass of cardiac muscle simultaneously. So by depolarizing all excitable tissues of the circuit and making the tissue refractory, the circuit is no longer able to propagate or sustain re-entry. Enable the natural pacemaker to resume control. So successful defibrillation is defined as absence of VF or VT at 5 seconds after shock delivery, although the goal is return of spontaneous circulation. This is in a scenario of a cardiac arrest. All right. So knowing about the mechanism is extremely important. So the factors that affect defibrillation success. So you have device related variables. So under that, the electrode placement, either anterolateral or anteroposterior. So they have seen that anteroposterior has been associated with higher resolution of AS to sinus than anterolateral based on small sample size studies. Then the pad size. The larger the pad, the better the success. Then handheld versus patch. When you keep handheld, there is improved electrode to skin contact and reduced transthoracic impedance. So that is associated with better outcomes because that will help in better delivery of current than with adhesive patch electrodes. Then coming to monophasic versus biphasic, monophasic waveforms defibrillate more effectively than, biphasic waveforms defibrillate more effectively than monophasic with less energy requirement. So there are going to be less risk of complications compared to monophasic. There are three important trials you need to know in relation to biphasic versus monophasic. One is the Orbit trial, the Timber trial, and the Orca trial. In Orbit trial, they showed that biphasic is superior to monophasic, and in Orca, they showed that biphasic is superior to monophasic. But in Timber, they said biphasic is non-inferior to monophasic. So the easiest way to remember it, that studies with O's had shown biphasic was superior, and the study with T had shown that they are non-inferior. Then you have patient-related variables. Under this, the first important factor that influences outcome is the transthoracic impedance. The higher the impedance, the lesser the success. That is, it has an inverse variation. So it is determined by factors like the energy level, the electrode to skin interface, the electrode pressure, the phase of ventilation, and the myocardial tissue and conductive properties. So all these factors come into play when you talk about the transthoracic impedance. Then the type of arrhythmias. In non-organized rhythms, the wavefronts are multiple and involve more myocardial mass, thereby requiring more energy for termination, like VF, pulse VT, or atrial fibrillation. And the duration of arrhythmia. The longer the duration, the lesser the success. Use of antiarrhythmic drugs. So, use of antiarrhythmic drugs has shown that if you use these antiarrhythmic drugs and proceed with defibrillation, there is a decrease in the energy requirement for defibrillation, especially with potassium channel blockers. Like potassium channel blockers and catecholamines have been associated with lower requirements, whereas sodium channel blockers have been associated with increased energy requirements. One of the examples of our potassium channel blockers is amidor. All right. Then patients with an underlying cardiac implantable electronic devices. Pad should be placed in the anterior posterior position to reduce the risk of damage to the implantable electronic devices. All right. So factors affecting defibrillation success, you can split it into device related and patient related. Under device related, you need to assess about the electrode placement, the pad size, the handheld versus patch, and monophasic versus biphasic. Electrode placement, they've seen that anterolateral is not as good as antero-posterior. And in regard to the pad size, the larger the pad size, the better the distribution of current and better the effect. Handheld versus patch, with handheld, there is improved electrode to skin contact. So better the shock delivered and better the response. With monophasic and biphasic, biphasic is supposed to be superior to monophasic. And under patient-related variables, transthoracic impedance plays a big role. Five important factors that determine it are the energy level, the electrode to skin interface, electrical pressure, the phase of ventilation, and myocardial tissue and conductive properties. The type of arrhythmias. If it is non-organized, then the wavefronts are multiple and involve more myocardial mass, thereby requiring more energy for termination. The duration, the longer the duration, the lesser the success, and use of antiarrhythmics. Potassium channel blockers and catecholamines are associated with lesser requirement and better success. And patients with cardiac implantable device, in these subset of patients, you need to shock them in the anterior posterior position with anterior position posterior electrode pad placement. So indications and energy selection. So this will be one thing which you all would already know. I'm just like revising it again. So for atrial fibrillation, you go with 120 to 200. If it is supraventricular tachycardia, a regular narrow complex, like atrial flutter or paroxysmal supraventricular tachycardia or AV and RT, you go with 50 to 100. Ventricular tachycardia with pulse, it is 50 to 100. Whereas if it is VF or pulseless VT, you go with 200. And if it is a monophasic defibrillator, you go with 360 joules. So coming to the complications, you can have ST segment and T wave changes, which are usually transient with no or minimal elevations in troponin levels. It is slower with the use of biphasic defibrillators. Then you can have arrhythmias or conduction abnormalities in the form of sinus tachycardia, non-sustained VF or VT, and bradyarrhythmias. Bradyarrhythmias are very rare. Myocardial necrosis. It is attributed to the sustained depolarization of myocardium, and it is associated with the energy delivered rather than the number of shocks. Thromboembolism, especially in patients with atrial fibrillation with prior left atrial appendage thrombus, thromboembolism is very high likely to occur. And other complications that can be there are pulmonary edema, transient hypotension, more sedation related, and cutaneous burns. So there is another part, the important complication you need to know is patients post cardioversion can go into cardiac arrest. So that also needs to be kept in the mind. During my resident days, when I did DRNB, we had one patient who had an SVT and he had shock with 100 joules. And post shock, the patient suddenly went into cardiac arrest. So for that, we had to initiate CPR. So this is it was only for one cycle. So it was not a problem, but it has to be kept in mind that cardiac arrest is one of the important complications you need to be anticipating. So with regard to defibrillators, one of the very important concepts you need to remember and know about is double sequential defibrillations. So this is coming up in a big way. So we need to know about it. So VF and VT, that is refractory to multiple defibrillation attempts, may occur. So in such patients, double sequential external defibrillation consisting of rapid sequential shocks from two defibrillators can be done. So that is what the concept of double sequential external defibrillation is. So you have two biphasic defibrillators and two sets of defibrillator pads. So for the pad placement, the first set of defibrillator pads should remain in their original location. That is, one pad is placed on the right upper sternal border and the second at the cardiac apex. For the second set, the anterior pad is placed over the precordium and the posterior pad is placed on the back in the left or the right infrascapular region. All right. So the technique is, if attempting double sequential defibrillation sequentially, then it is recommended that two healthcare providers each operate a single defibrillator device to ensure an intentional delay exists between the two administrative shocks. But there was some trial called the dose VF trial, where the intentional study had a single operator in the interventional arm. So this is just for knowledge purposes, but in practicality, having two people operate two different defibrillators would be a more pragmatic option. In 2020, the AHA guidelines, they had mentioned about double sequential defibrillation, but since this concept was in its infancy phase, its routine use was not recommended at the time. But there are a lot of benefits that are coming in relation to this. So we can possibly expect some positives in the next update. So this is one important study that needs to be known about. That is why I've kept a separate slide on this. Please concentrate on it. So the clinical question in was VF trial, that is defibrillation strategies for refractory ventricular fibrillation. Clinical question was, in patients with refractory VF, does double sequential external defibrillation or vector change defibrillation compared to standard defibrillation improve survival to hospital discharge? So many of you may look at this vector change defibrillation and be a little surprised. It is nothing new. It is just the probes being placed in the anterior and the posterior position. So, like I said, the main concept behind it is by placing it between the anterior and posterior rather than anterior and lateral, there is a theoretical advantage that it may reach the areas of the heart that are not fully defibrillated when you keep it in the anterolateral position. So that may help in improving outcomes. So that is what the concept of vector change defibrillation is basically about. So under intervention, you had a vector change defibrillation. That is all the subsequent defibrillations performed in anterior posterior pad placement. Then you had BACD. That is all subsequent shocks performed using BSADs. That is, like I said, one set of probes will be placed anterior lateral and another set of electro pads will be placed anterior posteriorly. And the third one is single operator press shock button on the anterior lateral. That is the routine standard defibrillation. So the control was standard defibrillation, pads placed in the anterolateral position. So the primary outcome was the time from survival to hospital discharge. It was significantly higher in the patients who had a double sequential external defibrillation than vector change than standard defibrillation. And the secondary outcomes, that is the return of spontaneous circulation, was higher in the DACD group than the standard care. So there was no difference between the vector change and the standard care. And termination of VF was higher in the DACD group than the vector change group than the standard defibrillation group. And the survival with good neurological outcome was again higher with the DACD group than the vector change group than the standard care group. So the main reason why I was emphasizing on this trial was it was a good trial and it has shown the important emphasis of double sequential external defibrillation. So it is an important thing to be known about because not only from a theory perspective, even from a practical perspective, you need to know about it because it will be coming up in a very big way. So coming to the last part of the discussion is about implantable cardioverter defibrillator. So the main indications is for either secondary prevention of sudden cardiac death. in patients with prior sustained VT or VF, or in primary prevention of sudden cardiac death in patients at increased risk of life-threatening VT or VF. All right. So these are the two main indications. Under AHA, they have recommended an ICD to be put in patients with LV dysfunction with an ejection fraction of less than or equal to 35% with an NYH grade of 2 or 3. Or patients with an ejection fraction less than or equal to 40 due to previous MI or at least 40 days post MI and inducible VT on VF on electrophysiological studies. All right. So these are the main indications for implantable cardioverter defibrillator. So the main ICD functions that can be done are ECG monitoring and storage, anti-tachycardia pacing, cardioversion and defibrillation, and bradycardia pacing. All these can be done through your implantable cardioverter defibrillator. So contraindications. If there are reversible causes of VT and VF like hypoxia, sepsis, electrolyte imbalance, or electrocution, it is a strict no to go with this because one is about the issues with placement, its use, and the subsequent maintenance and costs. And the components, like you had seen in a pacemaker, permanent pacemaker, there is a pulse generator which will have a battery and a circuit. Then you will have the pacing leads. That's the pacing leads and the electrodes. So the extra things here will be that you will have pacing and sensing electrodes, and along with that, you will have also defibrillation electrodes. That is what will be the added things in addition to the pacemaker, permanent pacemaker. So complications, we have short term and we have long term. Short term, you can have bleeding, thrombosis, pneumothorax, pain, pocket hematoma, Twiddler syndrome, that is twisting and misplacement of the device related infections. And on long term, there can be device related pain, anxiety, lead fracture, inappropriate shock delivery, or device infections. So these are the complications that can be anticipated with use of your implantable cardioverter defibrillator devices. So this is the last slide. So, sorry, this is the image of your implantable cardioverter defibrillator. So you can see the pulse generator, the leads that are there, and the electrodes that are being placed. So you can see the leads and the atrial electrode, and here you can see the ventricular electrodes. All right. So this is about the ICD. That's the implantable cardioverter defibrillator. So this is the last slide. So those who know the answers can put it up in the chat box. So we can just discuss it after that. So I'll give you 1 minute time to look into the X-ray and give you a diagnosis. Anyone? Excellent. That's the answer. So Parvati RS had answered. It's Twiddler syndrome. So yeah, you can see here, because of manipulation, there is twisting of your leads. So that itself can lead to malfunctioning. And they say it is most commonly seen in patients with psychiatric illnesses because they don't know the gravity of the situation and they tend to meddle with it so frequently, leading to this complication. All right. So thank you. So if you have any queries, please let me know. Or if you, when you're reading through these topics, if you have any doubts that come up in your mind, please post it in the WhatsApp group. We will be definitely there to help you out. So, like I said, defibrillators are very, very important from an exam perspective. Please do read about double sequential external defibrillation. It is very important. Read about the dose VF trial. It can be kept for critical appraisal and it can be asked by itself as a question because it is a very, very important topic. With regard to pacing, it can be asked as part of your bradyarrhythmias, or it can be asked in the practicals under your ECG station. So you need to know about it. So if anything else is there, please let me know. I'll be happy to share.
Thank you, sir.
Okay. So today is the next session by Dr. Niharika will be uh, done tomorrow. All right. So the tomorrow's class will be at around 5 o'clock. So there will be 2 sessions, like how it was yesterday. So this is just for your intimation. Again, in the group, the timing, the topics that will be discussed, and the presenters' names, everything will be updated to you all. Thank you.